It's my distinct pleasure to introduce Dr. Kathryn Schmitz. She's from Penn State Cancer Institute, and she will be leading this session. Take it away, Katie.
Okay, fantastic. Thank you so much, Nigel. Based on the way that we've organized this session, I'm going to go ahead and do introductions for all of the rest of the speakers now before I launch into our talks. I'll start by saying that this team has been working together for a little over a year on exactly the topic that you see in the title of our session. So I am absolutely delighted to introduce my friends, including Dr. Karen Bassenquist, in my view, the nation's leader in behavioral science on the topic of exercise and cancer. Karen is a professor of behavioral science and director of the Center for Energy Balance and Cancer Prevention and Survivorship at MD Anderson Cancer Center. Prajakta Adsul is an assistant professor in the Department of Internal Medicine at the University of New Mexico, and recently completed the Cancer Prevention Fellowship with the Implementation Science team at the National Cancer Institute, and is our resident implementation science expert on our team. And last but certainly not least is Dr. Laura Rogers, MD trained, but very much an exercise oncology clinical trialist. She is a professor at the University of Alabama at Birmingham in the Department of Medicine, the Division of Preventive Medicine, and has an extremely active ongoing research program that is relevant to our topic today. So we've actually made one long PowerPoint slide for set of slides for this presentation, and Prajakta is in charge of them. So you're going to hear us say, next slide, please. So the agenda for our session, we'll start with a presentation of the exercise oncology evidence base. And then we're going to present to you 3 case studies in the area of implementing exercise programs after diagnosis of cancer, including one from me, the Strength After Cancer program, after breast cancer program. And then Laura Rogers will present Beat Cancer, and then Active Living After Cancer by Karen Bassenquist. Dr. Adsul will then be presenting a brief primer on implementation science, and we're going to do a Q&A among ourselves and with you as the audience, and then we'll have our closing before we move into the final session of this event today. So next slide. So first, I'm presenting this exercise oncology evidence base. Next slide. The first thing that I want to make sure that this audience is aware of is that we do have a remarkable and robust evidence base in the field of exercise oncology. In fact, on the little bit left of this entire curve that you see on this slide, back in 1988 were the first human clinical trials that were done on exercise with human beings with breast cancer patients by 2 nursing researchers at The Ohio State University, Winningham and McVicker. By 1996, 2 legends in the field, Christine Credenreich and Carrie Cornier, did a review of the then available randomized controlled trials, most of them from Winningham and McVicker. And they concluded, not surprisingly, that we needed more evidence. By the time the American College of Sports Medicine published its first roundtable in 2010, there were 225 randomized controlled trials in the field of exercise oncology. And between that time and when the second ACSM roundtable happened in 2018, there was an exponential rise in the number of randomized controlled trials in this field. We now have, if you go look in PubMed now, for exercise and cancer and survivorship, and you cross it with randomized controlled trials, there are over 1,000 of them. Next slide. So as a result of that exponential increase in the evidence base, ACSM saw fit to run the International Multidisciplinary Roundtable on Exercise and Cancer Prevention and Control in March of 2018. And this was held, back when we traveled, remember that? I was lucky enough to co-chair this with my friend and colleague, Chuck Matthews from NCI. And you can see that there were a number of partner organizations in the room. Our goal was to bring in all of the various constituencies that touch the patient and deal with the patient in order to make sure that we had all different viewpoints in the room. Next slide. So this is a picture of us standing in front of the, behind the beefeater, who stands in front of the Sir Francis Drake Hotel in San Francisco. And you can see the logos of all of the partner organizations around the sides of the slide. Next slide. As a result of that roundtable activity, 3 papers were published, and I'm going to make short work of them, but summarize what happened with each one of these. Next slide. So the first of them was ably led by American Cancer Society epidemiologist Alpa Patel, and was really focused on whether physical activity would prevent cancer, primary prevention, as well as whether there was a role for physical activity in secondary prevention and prevention of mortality from certain common cancers. Next slide. And I'm showing you the results of this in an infographic, because we believe that it is time to try to share this information as broadly as possible. In fact, we've started an initiative through the American College of Sports Medicine called Moving Through Cancer, which has taken upon itself the idea of trying to make these kinds of infographics and share them as broadly as possible. So the conclusion of the review of reviews that was done by this expert panel for ACSM is that exercise does prevent breast cancer, endometrial cancer, kidney, bladder, esophageal, stomach, and colon cancers. And in the fine print at the bottom, what you might also be able to see is that for cancer survivors, exercise will also improve survival after a diagnosis of breast, colon, and prostate cancers. Next slide. The second paper that came out of the roundtable was very ably co-led by Kristen Campbell and Carrie Winterstone. Next slide. The goal of this second paper was for us to try to see if we could prescribe exercise like a medicine. Could we actually figure out how to prescribe exercise for precise side effects and symptoms after cancer treatment? And so this started with a review of 16 different cancer health related outcomes, mostly symptom related outcomes. And this was only a review of randomized controlled trials. The people who were the authors on this paper essentially undertook 16 systematic reviews for the process of one paper, which makes me laugh every time I say it. So we started with finding all the randomized controlled trials on, say, physical activity and cancer-related fatigue, and we looked at whether there were more than 5 studies or not. If there were 5 studies, we looked at whether the effect was close to 0 or greater. If the effect was greater than 0, then we looked at heterogeneity of effect. And in essence, if we make our way to the right side of the slide, what you can see is that we were able to conclude a strong fit prescription was possible, a moderate level of evidence fit prescription was possible, or we were unable to make a fit prescription. Next slide. So of these 16 cancer health related outcomes that were reviewed for this paper, we were able to make a strong fit prescription, which is to say that we were able to tell readers the frequency, intensity, time, and type of exercise that would be needed in order to have a substantive clinical effect on anxiety symptoms, depressive symptoms, fatigue, health-related quality of life, breast cancer-related lymphedema, as well as physical function. We had moderate evidence for the outcomes of bone health and sleep, and we were unable to conclude any benefit for any of the outcomes that are listed under insufficient on the right side of the slide. Next slide. So again, I'm back to my infographic story. This infographic, like the other that I showed before, is available at Exercise Medicine / Moving Through Cancer. And what we attempted to do by pulling together this infographic is to pull together all of the information that we had in those first 2 publications. So the first publication was about how to prevent cancer in the first place, or to improve the likelihood of survival of cancer for breast, colon, and prostate cancer. On the lower half of the infographic is the fit prescription, the very, very specific prescription for the 8 different cancer health related outcomes that we saw we had sufficient evidence to make those kinds of fit prescriptions. So for example, for cancer related fatigue, which is in green, and looks like somebody's very tired leaning over their desk, you can see that you can do aerobic exercise 3 times a week, 30 to 60 minutes in duration, or resistance training 2 to 3 times a week, 2 sets, 8 to 15 repetitions, or the combination of the two. So we actually have tested this with a number of seasoned professionals, and we have further tested it with about 33 cancer patients at this point. They needed more information than this, and we are in the process of developing a patient-facing pamphlet to go with this infographic. Next slide. The third paper to come out of the roundtable was about how to make it happen. This is the Exercise as Medicine and Oncology paper. Next slide. So the first thing that we were interested in here was trying to figure out how we could translate the exercise as medicine model that has been used in primary care to promote physical activity in the setting of internal medicine and family medicine into the setting of medical, radiation, and surgical oncology. So it looks like a lot of information on this slide, but it boils down to asking 3 questions and making a referral. So the first 2 questions at the top of the slide are the assessment questions. This is the physical activity vital sign. And the issue is, rather than focusing on the specifics of the words in those questions, that you were asking 1 to 2 questions of patients to see whether they are physically active as they are going through their treatment and afterwards. And this is intended to be done by healthcare providers who are seeing cancer patients and survivors on a regular basis. The third question is the gatekeeping issue. And this is recognition of the fact that not all cancer patients and survivors have the same level of function and ability to be able to be physically active. And so the question is, would you say that the patient would be safe exercising without medical supervision? If the answer is yes, the recommendation is to prescribe the level of exercise recommended on that infographic I showed a minute ago, and to refer to the best available community program. If, on the other hand, the clinician, and this need not be necessarily an MD, could be a nurse, could be a physician's assistant, if they don't know, or they're not sure, or they don't have the capacity to evaluate, then our recommendation is that that patient is referred on to outpatient rehabilitation for further evaluation. And then we allow the outpatient rehabilitation healthcare professionals to make the best recommendations for how to get this person moving. Next slide. We've created a prescription pad with the intention of making it easier for healthcare professionals who are working with cancer patients and survivors to assess, advise, and refer their patients into exercise programming and to be able to exercise just on a regular basis at home. Next slide. The other thing is that we recognize that there's a real need for us to be not just referring people to say, hey, go out for a walk, but that there be a program that we're referring people to. So we have developed an exercise programs registry. There is now 1,630 programs on this registry, including something between 4 and 8. We're working on sorting that through, that are virtual programs that could be accessed by patients anywhere in the country. And we're continuing to try to search programs. We're doing this on a state-by-state basis. Next slide. So this is what the current landscape looks like. Go back one more. The current landscape looks like in terms of the number of programs. Poor West Virginia doesn't seem to have any exercise oncology programs that we could find anyway. And you shouldn't be terribly surprised by the fact that New Jersey and Texas have the largest number of exercise oncology programs, because they are 2 states that have been a focus for the Live Strong at the Y program. So that's one of the reasons why there are so many in those 2 states. Next slide. All right, so that's a little bit of a flavoring of our evidence base. And now we're going to move into our case studies about implementing exercise. So the first one is from me, and then you don't have to hear from me anymore. So I'll be talking about the PAL trial. Next slide. So the PAL trial was a very large randomized controlled trial funded by NCI. It was an evidence-based intervention. It was delivered within YMCAs, but when we finished the trial and we attempted to see whether we could sustain the intervention based on the nature of what this intervention is and the population that was the focus for this intervention, we actually found that it was necessary to translate it back into the clinical realm, and it has become something called the Strength After Breast Cancer Program, which is based in outpatient rehabilitation, mostly physical therapy. Next slide. So the evidence base for the intervention is robust. The first two papers that we published, the sort of main results papers that we published on this were published in 2009, 2010 in the New England Journal of Medicine and in JAMA for the women with and at risk for lymphedema, respectively. And I just want to tell a quick story. It's sort of foreshadowing for our later discussion. When I published these papers in 2009, 2010, I wrote in the papers that people could write me and, and I would give them the protocol, and I figured that that was enough to be able to implement this program. That should be plenty for people to be able to implement this program. And I was shocked and appalled to find that not only was that not enough, but in fact, women were getting hurt because the people who were trying to implement the program did not understand sufficiently from what was published in these papers how to implement these interventions. Next slide. So I'm just going to have you click through the rest of this slide, and you'll see that there are a number of other papers that we published about quality of life and about skeletal health and about physical function and about body image that showed a number of benefits of this intervention. Next slide. So what is this? What is the PAL trial evidence-based intervention? It starts with a pre-intervention evaluation to ensure the safety of the woman with breast cancer to do the intervention, as well as a pre-intervention education session about her lymphatic system so that she understands what the risks are that she's undertaking. Then there are supervised exercise sessions with a well-trained professional teaching the biomechanics, proper biomechanics for the exercises, as well as the starting low, progressing slow concept of how to progress the resistance as they have learned how to do the exercises. Continuing the exercise in an unsupervised setting, and then returning to physical therapy for evaluation if symptoms change. So that's what we had from the randomized controlled trial from the R01, and that's what we translated into the setting of, oh goodness, I'm getting a phone call. There you go. That's what we translated into physical therapy setting. Next slide. Okay, so our key implementation questions as we went from the YMCA community-based approach to a physical therapy approach was whether PAL could in fact be delivered in this new setting. Could we get the sort of fitness trainer-oriented training to be appropriate for outpatient rehabilitation professionals? And the answer was yes. We had over 800 women complete the program during the 18 months that we tested the implementation. The second question was whether physicians would refer to the program. And I'm happy to say that 40% of the eligible patients that came through the Rena Rowan Breast Center at the University of Pennsylvania, which is where this work was done, were referred into the program. The big win was that insurance did agree to pay for the revised program. And in fact, you'll see in a slide or two that that continues to be the case. And then the other big question is, okay, now that you've revised the intervention so dramatically, we went from 13 weeks with a YMCA trainer to 4 sessions with a physical therapist. Does the intervention maintain efficacy in the new setting? And the answer gladly was yes. Next slide. So there were a number of implementation methods and strategies that we used. I would say in part, one of the most important things was identifying and partnering with a physical therapy champion who was able to work with the culture of the physical therapy clinic to help us to figure out how to translate this intervention into something that made sense to the physical therapist. There were a number of adaptations that were necessary to the intervention, in part because of the differences in the training of fitness trainers versus physical therapists. There was a huge need for us to assess the readiness of the physical therapy clinic as well as Rita Rowan Breast Center to do the referrals. We had a number of trainings that we had to develop and redevelop until they were right for the oncology clinicians as well as for the physical therapists. Our initial grant proposal for this implementation science had us doing an hour-long presentation to oncology clinicians to tell them all about our brilliant work. You can imagine that would not have gone over very well. We ended up with 10 minutes on the tumor board meeting. We did make changes into the electronic medical record. We added an automated referral, 3-click referral, we called it, for the oncology clinical care team to be able to make referrals into this program. We did come back to that electronic medical record to see whether or not they were actually making referrals. And we audited the electronic medical record frequently during the study. And finally, we did develop a toolkit to put this whole thing together so that this could go on the road and occur in other settings. Next slide. So we did use that toolkit to develop an online training for strength ABCs in partnership with Post Training and Consulting, which is a company that delivers continuing medical education to outpatient rehabilitation professionals. Over 700 people have completed this training now. It costs $125 for the 4-hour training. We do allow certified exercise professionals to take the training, but then insurance does not pay them to deliver the intervention. Next slide. I believe I have here a map of the distribution of the Strength ABC locations across the US. So if you'll go to the next slide, you can see we've done actually an evaluation of how this has gone. And we did get an answer back from, we at that point had, I think, about 300 places that had completed the course, and 96 of them responded, and most of them said that they had tried to implement it. 93% who had tried were still delivering it. And I think it's actually particularly important to note that 72% of these folks said that they were still receiving reimbursement for their services from third-party payers. So this does seem to be something that has some stickiness. And so we're very interested in continuing to evaluate the implementation, dissemination, scale up, and sustainability of this activity. Next slide.
All right. I'm going to speak just a moment about Beat Cancer. Next slide. Beat Cancer stands for Better Exercise Adherence After Treatment for Cancer, and this is a physical activity behavior change intervention for women with a history of any cancer type. Next slide. The efficacy of this intervention was confirmed in a multi-center randomized controlled trial, and we have reported significant benefits of the intervention on physical activity behavior, objective and self-report, as well as significant benefits related to cardiorespiratory fitness, quality of life, and a number of patient-reported outcomes such as fatigue, symptom, anxiety, and depression. Many of the benefits caused by the intervention either meet or exceed clinically important differences. Next slide. This is just an example of some of our efficacy data. It shows that the odds of meeting recommendations for physical activity among the women who received the Beat Cancer was significantly greater than that for those who were in the usual care group, which was written materials. And this significant benefit was noted based on both accelerometer and self-report, and was noted immediately post-intervention at 3 months, as well as continuing 3 months later. Next slide, please. So what is the Beat Cancer intervention? Well, it's an intervention which its goal is to gradually increase the physical activity of the participants, the women cancer survivors, so they are doing at least 150 weekly minutes of at least moderate intensity exercise. It consists of several components. First of all, there are supervised exercise sessions with exercise specialists. These occur more frequently in the earlier weeks of the intervention and are gradually tapered over time. And in the second half of the intervention, we transition them entirely to home-based exercise. And during that phase, the participants receive update face-to-face, can be face-to-face or telephone counseling with an exercise specialist every 2 weeks. In addition to these activities, the participants received or participated in a discussion group, and these groups were focused on barriers and other important factors that we had identified during our needs assessment and also from the literature, and included things such as stress management, time management, how to make developing behavior modification strategies that are tailored to the participant, and those kinds of things. Next slide. So having demonstrated the significant efficacy of beet cancer, we sought to understand how we might be able to translate and implement this in a rural, non-academic, non-research setting. So we obtained a NCI-funded R21 grant, and our goals were to adapt the intervention to this non-research setting and to cancer types other than breast, because the efficacy study was initially only in breast cancer survivors. We also had the goal of developing an implementation toolkit, doing proof of concept testing of the intervention in the new setting. And we wanted to do all of this in collaboration with a rural cancer community network site in Alabama. Next slide, please. So our key implementation questions related to this translation effort included, we wanted to better understand factors to consider related to setting and delivery. We wanted to identify potential implementation barriers and facilitators, and we wanted to determine contents for an implementation toolkit relevant for a broad range of settings. Next slide, please. Some of the methods and strategies we use, well, for funding, we obtained the NCI funding to cover the cost. We identified champions at the new site through institutional partnerships. I will point out there's a plural, it's champions, not just champion. We learned that it was very important to have more than one individual. We also worked on our leadership buy-in. We did multiple on-site meetings, and these meetings were ongoing throughout the process with the leadership turnover that naturally occurs as part of an organization. We were at times having to obtain buy-in from new leaders. We did obtain stakeholder input from cancer survivors, potential interventionists, and community and organizational stakeholders. And we organized this information according to the consolidated framework for implementation research. And we also were working toward improving readiness by training the staff at the site, as well as developing the toolkit. Next slide. So just a taste of some of the information that we learned about the setting and the delivery factors. Several very key aspects were readiness and engaging, and this is not only at the organizational level, but also at the interventionist and the cancer survivor level. We also identified that intervention characteristics related to design, quality, and packaging, as well as costs, were going to be important, and that it was also important to consider the patient needs and resources, as well as other community partners that the implementing organization may wish to partner with. Next slide, please. This is another set of examples that showed how we identified a facilitator and then identified possible strategies that we could use to target that facilitator or barrier, and then what implementation outcome this may influence. For example, a cancer survivor said it would be a facilitator if this were a convenient location. Makes sense. And they also suggested distance delivery and collaboration with community organizations who are located in the neighborhoods of the cancer survivors. And we would expect that this would influence implementation, adoption, acceptability, and reach. The interventionists, one of the facilitators they identified was that it would be important to provide free transportation for participants. These are rural participants, and if they have to come, if they have to travel for the exercise, that it would be important to provide gas cards and or use existing public transportation services. And this would be expected to improve acceptability, reach, and adoption. This organizational stakeholders, some of the factors they mentioned included staff training, the importance of staff training, good communication tools, and physician buy-in. And some potential strategies include, for addressing this, include facilitation, the toolkit, webinar training, identifying a physician champion, and making the intervention part of the patient, or referral to the intervention part of the patient care plan. And we would expect this to improve fidelity and adoption. So that's just some examples of those potential facilitators and related strategies. Next slide. As far as our toolkit, our contents of the toolkit were derived from three main sources. The research manual of procedures was used, as well as a literature review, and then the input that we obtained from focus groups, nominal group, technique groups, and photo voice that were done with the cancer survivors, interventionists, and the organizational representatives. All that information was used to develop the toolkit. Next slide, please. The toolkit includes a manual, which is very detailed and includes an appendix as well. It includes PowerPoint slides for interventionist training and the group sessions, as well as a participant notebook and also some 11 staff training videos. Next slide. So putting this together, just to show you an example of how we took some of our information about important factors and implementation barriers and facilitators and weave this into the toolkit. This is just an example. You can see the table of contents on the left there shows what was in the manual. And one section talks specifically about the core components of the intervention. So in other words, we were trying to explain what was the goal of each of the components of the intervention, so that adaptations could be done to overcome some of those barriers. And then we had a section where we talked about, here's how you make an adaptation without losing that core component, and then provided, for example, some suggestions on how you might do that. How you might adapt without losing the core components. Next slide. So I'll turn it over to Karen.
All right, thank you very much. Next slide, please, Prajakta. I'm going to talk to you briefly about the Active Living After Cancer program, which we are implementing now in communities throughout Texas. Next slide. So the Active Living After Cancer program was initially adapted from Project Active, a lifestyle physical activity intervention that was developed and studied at the Cooper Institute in the 90s. So they found that this lifestyle intervention compared favorably with a more structured exercise intervention for healthy but inactive adults. So it improved physical activity, fitness, as well as cardiovascular risk factors. So we adapted that program for cancer survivors and tested it in 2 trials. The intervention itself is not a typical supervised exercise program. It's really a series of group sessions to teach cognitive and behavioral skills for increasing physical activity and incorporating it into daily life. In the original program, it was taught once a week for 16 weeks and then every other week for 18 weeks, so a total of 24 sessions. As I mentioned, we did 2 trials. The first was with prostate cancer survivors on androgen deprivation therapy for metastatic cancer, and we did not see effects there. But in the second trial, where we made some additional changes, incorporated a little more structured activity into the sessions, we did see positive effects, and that was done with sedentary breast cancer survivors. The intervention participants saw benefits in terms of physical aspects of quality of life, as well as objectively measured physical functioning, as shown on the graph on the right here, shows their 6-minute walk distances. Some of the underlying kind of behavioral processes that we would expect also changed. And we did see progression in terms of stage of change, but not in self-reported physical activity. I could talk about that later, but we can discuss that more in the discussion if you like. Next slide. So we eventually decided to adapt this program to deliver it in the community. So really, adaptation was our kind of key implementation question. In conversations with our partners, they said that 24 sessions were too many and that we would have to make some changes. So we began to think about how to adapt the program. This slide shows sort of a steps of adaptation process of evidence-based interventions based on an article by Ascafri and colleagues. Our adaptation really focused kind of on the bottom 2 lines here, thinking about the talking to stakeholders, figuring out what needs to be adapted, training staff, and testing out these adaptations. So next slide, please. Just to sort of describe some of the aspects of the program that needed adaptation, as I mentioned, we were moving from a context of a research study into a community setting where it was taught by health educators rather than our research staff. So we needed to adapt the training program to provide them with more support and more education in doing the intervention. We needed to shorten it, and we also needed to simplify the materials. We really wanted to develop this so that it would be accessible to cancer survivors who had low health literacy, who were medically underserved, who were low income, and non-English speaking, or specifically Spanish speaking. So we needed to simplify the materials, translate into Spanish, and make sure that the photographs and the written materials had cultural relevance. As well, we of course changed the evaluation and simplified it greatly in the community adaptation of the program. Next slide, please. So the program ended up as a 12-session program. It's been funded by the Cancer Prevention and Research Institute of Texas for the past 7 years. We just received our 3rd grant to expand the program further. The sessions are done once a week. They include 3 parts, really. The first part is the cognitive and behavioral skill training on the topics indicated here. In the middle of the session, we do some structured physical activity with really a focus on moderate intensity activity and teaching a kind of a range of different activities so that people get exposure to different things that they can do to be active. And then we wrap up the session with a survivorship topic. So this is currently being conducted via Zoom. We've had over 1,000 survivors and caregivers who've enrolled in the program so far. Next slide, please. Just to give you a little taste of the results from the community implementation, as I mentioned, we've had just over 1,000 who have participated so far. The first phase was done in Houston only. In phase 2, we expanded to El Paso. And in phase 3, we now are expanding to the Tyler and Beaumont and Rural East Texas areas. So below that are some results from phase 2 specifically. We have served a really diverse group of cancer survivors, including a large number of Hispanics and a large number of people who speak primarily Spanish. So we feel like this program is reaching a population that isn't reached by a lot of programs. On the right, you can see the improvements in physical activity. We do allow caregivers to participate with a survivor if they like. And so we see that At follow-up, there's a higher percentage of both survivors and caregivers who report at least 150 minutes of moderate to vigorous physical activity, and they also improve on their sit-to-stand test performance. Next slide. So thinking about some of the implementation strategies that we've used to move this into the community, you know, it kind of moves in phases. So starting with sort of the exploratory phase of deciding to implement in the community and looking for ways to do that, it was very important, of course, to identify the funding sources and develop relationships with community partners who could help us recruit participants and also teach the program. In preparation phase, we needed to, of course, develop some formal commitments with those partners, do the adaptation of the intervention and the training strategies, train educators and pilot test the adaptations. And in the implementation phase, which of course is ongoing, we needed to promote the program. And in fact, you know, promotion of the program takes way more time than you expect in the beginning. So making sure that people in the community and in the medical community know about the program and can refer cancer survivors. Our role at MD Anderson as the Training and Evaluation Center, we distribute the materials and provide technical assistance and ongoing training and support. So, you know, when we started the program, we did initial trainings for the health educators, but we recognized a need for providing some ongoing support. So we're now using Project Echo, and we have sessions once a month where the health educators learn about some topic related to physical activity and cancer survivorship through a more didactic presentation, and then also present a case so that they can get feedback and about issues that they're experiencing in the implementation of the program. Next slide, please. I think the kind of key takeaway on implementation is that that partnerships, adaptation, and providing ongoing support, at least for this program, are all really critical to the success of the implementation. And furthermore, that they're not sort of one and done strategies. They need to be continuous throughout the implementation, that you have to keep establishing and fostering those partnership relationships. The adaptations that we've made have, you know, we did the initial adaptation, but adaptation has continued, including some really creative adaptations that the health educators have initiated. And of course, in March, we experienced a very major adaptation of having to move from an in-person to a virtual group, which many people who deliver programs are dealing with. But so we've been able to do that successfully. But we continue to learn and change and monitor the effects of those changes on program success. And of course, providing ongoing support for the people who are implementing. And I think this arrow sort of indicates that those should all keep going, but I think we could also put in that arrow funding, because of course, you can't just keep providing programs without some funding and support. And we've been fortunate to get some great support from the state of Texas. Next slide. Just to close, you know, this is sort of the philosophy underlying this, that it was not enough just to know this program worked, but we wanted to apply it. We wanted to see the program done in the community. Thank you.
Hi, everyone. So my name is Prajakta Adsul, and I'm going to carry the next 10 slides for you. So just to reiterate, though, what you've heard from these three stellar presenters is not just this focus on evidence and how these evidence-based interventions were developed, designed, and brought to life, but also this focus on implementation. And so it is my distinct pleasure to sort of give you a very quick snapshot of implementation science within this context. So I'm just figuring out my slide movement. Yeah. So just to iterate, evidence is only as good as how and whether it is adopted, whether providers are trained to deliver it, whether trained providers actually deliver it, and if eligible, patients receive it. And we know from previous research that it takes, if you think through the publication pathway and the pathway from research to translation, we know that it takes around 17 years to turn 14% of original research to the benefit of patient care. So with these presentations and these case studies, I hope we've made the case for you is that there is no miracle that's going to occur. It's just really patient and systematic work of thinking through what strategies, where, and for whom we can make this evidence more applicable and therefore more real world, with real world applications. So what is implementation science? I just wanted to tell you the NIH definition is the study of specific methods to promote the integration of research findings and evidence into healthcare policy and practice. And often this is the black box that is between, an evidence-based intervention to how we achieve health outcomes. And while we're thinking about this, it is very well exemplified in all of the 3 case studies, how we need to consider context that evidence is being implemented in, previous research, the need for adaptations to fit different settings and different populations, and along with just the current implementation, also thinking about how do you sustain and scale up once effectiveness is achieved in implementation. There is a lot of influence of communities, healthcare organizations, providers, and their teams, and the external environment on patients and on how evidence gets implemented. But there's very limited information about this in peer-reviewed literature. So that is the whole point of why we wanted to present these cases to you, which reflect several years worth of work in this direction. It also is important to acknowledge that change is constant, context is dynamic, and therefore it makes implementation really complex. What helps in this space then is theories, models, and frameworks that have that we have about around 100 of the last time that I checked in the DNI models web tool, which I've put the link over here just in case any of you are curious to see what these are. And it really helps to think through, well, you have an evidence-based intervention. How are you going to implement it? What is the approach? And are there theories to help you think about that process? Are there theories on the bottom here to help you think about what would determine the implementation approach? What are the determinant frameworks? So for example, Dr. Rogers presented the consolidated framework of implementation research, which helped her understand what the factors were that would influence implementation. You could focus on what the implementation outcomes are, and there are evaluation frameworks that help with how you could be guided in identifying the outcomes and studying them. And then there are outcomes that are more at the health system and the clinical level that could also be assessed in your implementation efforts. An example just to give you is the EPIS framework, the Exploration, Preparation, Implementation, and Sustainment Framework. And it basically walks you, and I think Dr. Karen walked you through the strategies that were specifically in the phase of exploration, where we evaluate the needs and the program fit, the stage of preparation where we plan to integrate into the system in which we want to implement this program, and then put the program into place in the implementation phase and see if this program can then be sustained and maintained within this system. Feel free to look at this EPIS website, which has a lot more resources and more explanation on these phases and the specific strategies within these phases too. When we speak of strategies, we consider them as methods or techniques used to enhance the adoption, implementation, sustainment, and scale up of a program. And I must acknowledge that there are several terms, several ways in which we distinguish what these methods are. And there's some inconsistent usage and operationalization of these terms. But the study that was done in 2015, which was the expert recommendations for implementing change, has served as like a a baseline taxonomy that identified 73 strategies. And here's just a quick snapshot of these strategies that the study tried to define and operationalize, and eventually hope that the literature would get consistent in the way we were operationalizing these in the implementation science literature. So just as an example, an evaluation and iterative strategy might be assessing readiness for implementation, which you've seen in some of the case studies that we've talked about. So how does this all apply to exercise oncology? There are tertiary benefits for cancer survivors, and yet this evidence has infrequently been translated for broader use. And this is really how the four of us have come together in thinking about how does it work? How do EBIs work? Where and under what conditions does the EBI work? And for whom does it work? So on the right side, you see cancer survivors being at the center of this figure, but we really have to start thinking about how are we delivering the intervention? Where are we delivering the evidence-based intervention? And frankly, where do we begin with all of this? So we brought together these 3 case studies, and what we did was, if you've noticed, all of the 3 case studies were presented in the specific evidence for this intervention, what the EBI was, and what the key implementation questions were for each of the case studies, and what methods and strategies were used in each of the case studies. So what we did together is that we mapped these on into the exploration, preparation, implementation, and sustainment phases, and really tried to operationalize each strategy that was used per the ERIC study. And if you see, this is just a very quick snapshot of a huge table, and hopefully we can share the publication with you soon. But if you see, exploration had a few strategies, and I think that was really because of the fact that the 3 case studies operated from a very strong evidence base, so knew and understood where the evidence was coming from. And then significant efforts were put into the preparation and the implementation phase, and then slowly moving towards sustainment where much work remains to be done. And mind you, I did not put arrows within these phases because these aren't, as we were discussing what was used in all of these 3 case studies and how this came to be, this was not always a linear process. It went back and forth between some of these phases. There was a lot of reiteration and development of these strategies and designing of these strategies such that they met the need of the implementers and the populations that their EBIs were implemented in. So just wanted to give you a snapshot of how these 3 case studies together have helped provide this starting point for future efforts in implementation of exercise oncology interventions. How can implementation science help moving forward? A little bit of pun intended there. We really encourage folks to come together in focusing efforts on the systematic study of implementation strategies, considering strategies that might be particularly relevant for promoting health equity, specifically, thinking about stakeholder engagement, the idea of advisory boards. We also think there is an opportunity to, as we are generating evidence for interventions, to think about generating evidence for implementation. And while you're thinking about implementation, also a focus on sustainment and scale up. So this was just a very quick snapshot of like multiple years of research, in which I could teach a whole course in implementation science, but trying to limit it here. And I think what you guys would be most interested in is from hearing from the panel in how they got started and thought about implementation. So we put up a few questions here for the 4 of us to answer, but we would encourage the audience to please send in more questions, and we would love to talk about them. So I think we all come online now, and we can get started with the Q&A that we prepared for this session. So you see, all of us are here. So would you all be kind enough to tell us where and at what point did you become focused on implementation for your specific interventions?
Well, my answer is, I've already given my answer and I'll just repeat it because it's a funny story that, I was silly enough to believe that, my God, it's published in JAMA. What else do you need? Go do it, So that was my wake up call. And that was a decade ago.
So for us, there was really a question of when we have enough evidence, right? So we had so the initial 60-person pilot test was considered a pilot test, and our plan was to get additional R01 funding and do a larger trial and show, have a stronger test of the benefits of the program, but we were never able to get that funded. And so several years went by. So I sort of set it aside. You have to kind of choose your battles, I guess. And I set it aside for a while, but then a community partner who actually had helped us in the trial to recruit patients for the study and to provide locations for the intervention came to me and said, we really should do that program. It worked. And so he's like, let's apply for this secret money. And so it really was prompted by the community partner. And we decided, we looked at the evidence that was part of the original Project Active trial that the Cooper Institute generated, which is quite robust, added into it our pilot test with cancer survivors and made the argument that, hey, this is enough evidence. And maybe that's why we didn't get funding for a trial, is that we had enough, and I just should have woken up and seen that earlier. But so really a lot of it was really prompted by the community partner, and of course our desire to make this more broadly available.
I think my experience is a combination of what both Katie and Karen said. We had a small pilot, it worked very well, but I was not comfortable moving forward without stronger evidence. So that I was fortunate enough to do the efficacy study with the larger trial. And then once I did, I was very pleased because I've got this really effective, efficacious intervention. But I was a little bit like Katie. It's like, okay, now what? I don't want it to sit on the shelf. I want to get it out there. And that's when I really began looking into implementation as implementation science is a field, and thinking, okay, how do you do this? And then I realized too that we just didn't have the materials for doing it, and it was going to require some, investment there. So I was glad that we could get the funding to really invest in that toolkit.
I should acknowledge, Dr. Rogers, it was you who brought all of us together in thinking about coming up with what is the generalizable information that all three studies can help us move forward in cooperating implementation science. So much kudos to you. We're seeing a lot more questions, but I'm going to try to sneak one more in before we go into the audience questions, and want to see, how did each of you choose and select the specific strategies to focus on when thinking about implementation? And I would also piggyback one audience question, which said, how did some of the strategies in the exploration phase versus the sustainment phase differ? How did they differ for you guys?
So I might start with I'll start with this one. I'd say we chose our strategies based on both pragmatic and scientific reasons. We had the pragmatic goal of getting this organization ready to implement the intervention. They were, fortunately, for the most part, they were very enthusiastic about doing the intervention. So that part of readiness, we didn't really have to work on quite as much. And so there was a pragmatic piece around, okay, how are we going to actually do this? And then there was the scientific piece, when I was thinking, we want to collect this information and do it in such a way that it's rigorous enough that it may help other individuals who were trying to translate or implement some of these more complex types of interventions. I would say, as far as your second question, we're not in the sustainment really right now, so I probably don't have quite as much to say about that. So I'm going to learn from Katie on that one.
Yeah. So I'll jump in and say that I think that you know, the way that we chose our strategies was based on where we were stuck. You know, so for example, we really were just astounded by this one incident. You know, there was this assumption on the part of the clinicians in one particular group that if they pressed the button in ERIC that the referral was happening, that someone was going to call the woman and set up the appointment. And that was true for them for CAT scans and other things, but it wasn't true for this program. It wasn't true for Strength After Breast Cancer. So so I think that we kind of did it backwards. Prajakta, I think we chose our strategies chose us because we got stuck and we were like, well, what strategy do we need to solve this problem? And as to sustainment, I would say that that is an area that is ripe for Strength After Breast Cancer. We're there. We're in, you know, I think 781 places as of today. So, you know, so what are they doing? How are they doing it? How are they sustaining it? And what's the variability look like? One of the things that I'm really eager to do is to do something that's much more planful, you know, where we plan the strategies to begin with to understand sustainability. So I'm excited about that. And that actually answers one of the questions from the chat as well. What's next? That's what's next for this work.
And I would say our selection of strategies was quite pragmatic. You know, we knew that we had to make some adaptations. For one thing, part of the application for the CPRIT funding requires you to estimate how many people you're going to serve, and and the cost per person. So you know, basically you're supposed to take your budget and divide it by the number of people served. So and we recognize that a 24 session program taught by master level people was probably going to be, you know, much too expensive to really be palatable. And the other thing is that we definitely wanted to reach kind of more vulnerable populations, that we wanted to reach out to the Spanish speaking population of cancer survivors. We wanted to reach more medically underserved and people with low health literacy who might not have be able to access other kinds of programs. And so the materials that we had initially tested were quite text dense. We needed to do a lot of modifications for health to make them more appropriate for a population with lower health literacy, and kind of increase the cultural relevance of the materials for Latino population. So adaptation was, you know, going with the adaptation as the primary strategy of the first strategy was really a very pragmatic choice for us. And as far as sustainment, you know, I think that is, it's a great question, and it's one we struggle with. Right now, we do have funding from the state of Texas to provide this in Texas, but it's not a program that we ask survivors to pay for. It's not a program that insurance companies typically would cover at this point. So the idea of having a stable funding stream is really a challenge. And one thing we're doing right now is we're testing, kind of exploring a model where organizations can come to us and to give them the training to provide the program themselves to their cancer survivors, to their constituents. So we're working with some healthcare organizations and also working with some churches to see if their volunteers can be trained to teach the program and deliver it that way.
So I think I'm going to jump in really quickly and just kind of clarify the figure that I had shown, which said developing educational materials in under exploration and developing educational materials under sustainment, at least based on the 3 case studies that we saw, is that some of these materials had to be changed, had to incorporate additional considerations as we were thinking about sustainability versus when we were just exploring for implementation. And some of these nuances, just because we've been able to aggregate these data across these 3 distinct case studies, we are beginning to see and we are beginning to learn. So much of this for even the 4 of us has been a learning process in understanding how do we apply the concepts and the methods and the theories in implementation science to actual implementation practice of these exercise oncology interventions. So hopefully this is proving to be a starting point, but not the end point. We are beginning to understand this. We are beginning to tease this out and be more specific in what we are generating evidence for, in addition to intervention, but also implementation. So I think I'm going to switch to an audience question here, because we cannot have any panel without talking about COVID. So wanted to get your.
Do you want to stop sharing slides and we'll just be a panel and we'll go to the audience questions?
Yes.
Okay. Well, there's a lot of them, and you started on the COVID one. So you want to ask those questions?
Yes, we could just quickly answer this one. What are some of these strategies, according to your experiences, that would help maintain these programs during COVID? So if you guys want to take a crack at that.
Well,
virtual.
What we did is, we took our groups and began doing them virtually over Zoom. It actually was something that we had planned to test out because we wanted to expand to some rural areas where we thought that people would not be willing to drive. So we wanted to look at some teleconferencing and video conferencing methods, but we didn't know we'd be suddenly dropped into it, on March 10th or whatever, when everything shut down. So I will say, we had some really, really creative health educators and effective health educators who really kind of made the most of it, even though I know when we initially told them about going virtual, they were not really in favor of it. They made the most of it. The story I love is that, of course, on Zoom calls, there's always concerns about people freezing, the screen's freezing, and there's lots of frustrations with the technology. So they would do, usually once during the 12-week session, they do a theme from the movie Frozen each week. And one of them made like this wig for the Elsa wig and stuff like that, just to make a joke out of it and to take it lightly instead of, being stressed by that, because of course it's stressful for the participants too. But it's been pretty successful. We're seeing similar outcomes and actually better retention in the program as it's gone virtual. So we have for our Zoom or virtual, well, for in-person, we had about 69% retention, and we're seeing about 88% retention on the virtual. Yeah.
How have you? Can I just jump in and ask you a quick question, Karen? Are you able to now reach rural folks better as well?
So theoretically, yes. I mean, we have not, we are just starting to work with our new partners who are going to help us reach out to the rural areas.
Okay.
And I think that a barrier we're going to have there is broadband coverage, right?
That's why I'm asking.
People can call in by telephone for Zoom. It's not the same experience. And so, we're going to have to do some adjustments there and really, work with people and first of all, find out, what they're able to do and then work with that, see what we can further adapt.
Right.
Karen, could you speak a little bit more about Project ECHO as well? Because there are some questions about mHealth that are coming up. And I think there is this idea of not just supporting the patients, but also the providers that are delivering these cares, and how can we get them more supported?
Sure, that's a great question. So some of you may be familiar with Project ECHO, which originated at the University of New Mexico. The idea behind it is really to help healthcare providers outside of kind of major treatment centers to have support for providing treatment in areas that they may be less familiar with. So where it started was with treatment of hepatitis C. There was like one hepatologist who was providing treatment to patients from all over New Mexico, and instead he developed Project ECHO to teach providers around the state how to manage hepatitis C. So we have kind of adapted Project ECHO for the health educators, and we once a month we have an ECHO session. Each ECHO session has a didactic component where there's sort of a lecture, if you will, from an expert on, sometimes it's an expert on fatigue, or sometimes it's an expert on, you know, incorporating resistance training, or teaching about nutrition, or any of the things that are relevant to the health educators as they teach the curriculum. And then in the second half, the health educators actually present a case. So, you know, if this were an echo of healthcare providers, they'd be, you know, presenting a case study of a patient, right? And so our health educators can do that. So it can be a problem they're having with a particular participant, or a success that they had with a participant that they want to share. But it more often is something about the program in general, you know, how to get people to tune in on time, how to you know, reinforce attendance at the sessions, that kind of thing. And so the health educator presents the problem, the other health educators and experts that are on the call kind of brainstorm solutions, and it's quite effective as a way to sort of continue that training on an ongoing basis, rather than like training somebody at the beginning and assuming that they're going to just be fine with what you've provided.
Dr. Rogers, I have a question for you. Among your cohorts, what are some of the greatest predictors of achieving the recommendations among cancer survivors?
That's a good question. So if we're talking, I assume we're talking about the individual, at the individual cancer survivor level. Pre-diagnosis physical activity is a major predictor. So obviously if they were doing it before their cancer diagnosis, they're going to be more likely to do it afterwards. In our own studies, for those individuals who learn to cope successfully with a variety of exercise barriers, they're better able to comply, as well as those who have social support. So I guess those would be the main ones.
Could you also talk a little bit about what you see as the next step for your program, since
Sure.
some of us covered it? Yeah,
I'd love to. So we are working on adaptations of the program to delivery channels that are more scalable. So we've tried to take what we learned through the core components, looking at the core components in our program evaluations and some of our mediator analysis, and we're working on a web-based intervention as part of the Amplify Program Project Grant, which is led by Dr. DeMark. I'm also have a pragmatic arm of next steps where, doesn't make sense, arm and next steps, but anyway, I'm working closely with our cancer rehab folks here to try to figure out how to better integrate exercise within the cancer care here. It's a slow process. But as we think about that, I'm also thinking about how do we perhaps take some of our adaptations to virtual delivery and that kind of thing, just like Karen talked about, how we can leverage that to make this more feasible for integrating into the cancer care.
thanks, Dr. Rogers. Dr. Schmitz, I have two questions for you.
Okay.
One is, you said in your study that you found certified exercise trainers were not always adept or prepared to promote exercise safely. What does this mean about frequent advice to health professionals to check for CETs for referrals?
Right. So I saw that in the chat and I was like, ooh, I hope we get to answer this one because clearly I gave a misimpression. You know, I don't know if you guys heard what, you know, what the writer said, in which case I really misspoke. What I was intending to say was that, you know, when clinicians make a choice about whether to send someone to community-based exercise versus send them to outpatient rehabilitation, they have to make it on some basis. And, you know, one of the simple ways that I describe it to oncology care providers is would you sign the piece of paper for this person to go to the Live Strong program? And if the answer is yes, then they can go to a community program, whether it's Live Strong or not. If it's no, or you don't know, then send them to a PT for further evaluation. The other thing that I did say, and I wonder if this is where this came from, is that certified exercise professionals can take the training to provide strength after breast cancer, but do not get reimbursement for it. And that has nothing to do with their training and whether they are qualified to deliver the program. It has to do with what gets paid for. It's just a matter of the exercise professionals in the United States are not allied healthcare professionals. They are in Australia, they are in the UK, they are in other places, South Africa, interestingly, but they are not in the United States. And so as a result, there's no reimbursement for exercise professionals. So I'm so glad to get the opportunity to clear that up.
Yeah. And I think great segue into the next question, I think, which all three of you might have some information to share with the audiences. Dr. Schmitz, you mentioned that insurance does not yet cover exercise programs led by certified exercise specialists. What do we need to prove and to whom so that insurance does cover this?
I'm actually having this conversation right now with an insurer. I'm actually having this conversation. So no, I think this audience should know these conversations are happening. They're happening right now, with various different insurers. And, and the answer of, what evidence do they want seems to vary by insurer. What's that about? So, the insurer that I will not name that I'm currently talking to seems to want information from the epidemiology research on recurrence and mortality. So yeah, I think we have an opportunity right now, and I think this is going to shift. I'm getting a note that we're over time, and we need to move on to our next session. Karen or Laura, do you want the last word before we go back?
No, we just appreciate all those great questions.
Yeah, it's wonderful discussion. Thank you.
Yeah, it really has been. Okay,
yeah,
fantastic.
Sorry, we didn't really keep our time. I was thinking we had another 15 minutes. Anyway.
This is very typical for the four of us. We just want to talk.
So thank you for all of the questions, and I hope you will reach out to us if there are any other questions that come to your mind.
Please do.
Thank you.
Please do. Okay, I think we're moving into another session.